So welcome to the surgical panel. We have a great group of people. You met Ehab El-Reyes from Cairo. We have Robert Devigne from Canada, Sunir Garg from Philadelphia, Dante from the beach, and Andrew Mashvegi. So thank you for participating, guys. I'm John Prenner from New Jersey. These are my financial disclosures, not relevant with the exception of Alcon, where I'm a consultant. So I thought when I was asked to run this panel, I would take advantage of your expertise and run through cases of mine that have recently caused me to have some anxiety and get the expert opinion to help me with my patients. So we're going to start with a case of a 45-year-old phakic woman. She has, in her right eye, she has a giant retinal tear that runs from 6 to 12 o'clock, and it's very anterior. So anterior enough that on an Optos photo, you can't see the anterior flap. But she's macula on and quite anxious. So, Sunir, what is going to be your surgical approach for this kind of case?
So you'll definitely do vitrectomy. There's no question about that. Buckle's a little bit controversial. You know, we did a study a few years ago looking at this, and if people are about 5 clock hours or more, the buckle's probably not adding that much. They've functionally created their own relaxing retinotomy. But in a younger person who has a weird vitreous space, I'll probably have a low threshold to put an encircling band around this individual, which is what I would do here. Assuming they're myopic, I would tend to use a 42 band. I pull it up in the beginning before I start the vitrectomy. It's just cleaner for me to do it that way. And the lens is going to be an issue. If it's that anterior, having access to the peripheral retina to laser it without hitting the lens can be an issue. Sometimes I'll move my cannulas around to get better access to the periphery without necessarily going 180 degrees across, and that's worked out pretty well, but sometimes I do end up touching the lens.
Dante, does the location of the giant tear influence your decision to place a buckle or not?
I think a little bit in this case it does. Two things, the location that's going down inferiorly, and you could always extend the retinotomy of some if you wanted to and just do a vitrectomy, but in a young patient who's still phakic, very anterior break, it may be hard to dissect anteriorly. I think I'd use a buckle in this case. She's going to need I tend to like to use gas in these cases too, and so the buckle adds a little extra support, because I think in this case it looks like there's almost a little bit of PVR towards the bottom edge of this as well. I tend not to really pull the buckles up till after I'm under gas if I'm going to do that, or air, because I'm worried a little bit of slippage, but that may just be hocus pocus, I don't know. And I certainly wouldn't do a lensectomy to start with, because I think with the small gauged instruments and stuff, we can really dissect with some depression, using a chandelier, really get the flap out. And even if you don't get all the flap, it doesn't really matter.
Okay, great. So you proceed with your vitrectomy, and the anterior flap cannot be removed without risking lens compromise. So Dr. Devigne, does this have to be removed? So this anterior flap, you're going to be able to leave a piece of it, or do we have to take it out? Are we concerned about ischemia the way we are with the anterior flap of a PBR-type retinectomy? What are your considerations here?
I look upon this completely differently. I would never, ever do a buckle. I can't remember when I've last done a buckle. And also, from my perspective, once presbyopic, the lens is of no value to a person, and not to mention whatever cataract they have will undoubtedly get worse after a vitrectomy, and especially after the gas exchange, et cetera. So I don't think there's any logical reason to leave the lens. So 100% for sure, I would just do a phaco and a vitrectomy, gas, easy case. I think to do buckles and leaving the lens, it's just an unnecessarily lengthy and complicated procedure.
Dr. El-Reyes, are you going to have to remove this flap of residual retinal tissue? Is it going to become a problem in terms of ischemia, or perhaps a nidus for trapping aqueous or fluid during air fluid exchange?
I would start this case as a phaco-vitrectomy from the bridging, so I can also do indentation and remove the flap, especially when you saw the picture, it's very anterior located tear.
Now, in the U.S., none of us, I'll speak for the panel and myself, we don't know how to do phaco anymore, and so it's either lensectomy or you got to keep it. So I kept it. And my hope was that we would not have to remove this little bit of flap. I don't think it causes ischemia, and we decided to proceed. One thing you could consider is maybe moving the position of the infusion to get a better angle on that anterior flap, but I didn't think of that during the case, just after. So things go swimmingly, and you're able to reattach the retina under perfluorocarbon. You do have a buckle that Sunir made us put on. It's an appropriate height. Laser's been applied. Everything is going nicely. And now what? Your next move, Andrew?
Certainly, I would flatten the retina with PFO, go to air, then use gas. I can't remember the last time I used silicone oil for a GRT. I usually don't do a buckle. That's what I would do. C3F8.
Fair enough. So you chose an air perfluorocarbon exchange, and since we had our buckle on, it helped to have the retina slip. So now I have a slip retina. Sunir, what should I do next?
Usually I share with my fellows most of the bad words I know, and then I will basically start over. I used to try to do things with the scraper and try to pull the retina back up and rotate the eye and all those things. I end up spending more time in the eye, so I end up putting in some perfluorocarbon to protect my macula, turning back on the fluid, and starting again. I'm pretty adamant about rotating the eye so that the break is dependent and staying there for about 5 minutes to drain. And I don't continuously suck. I like to sort of intermittently suck and just look at the rate of fluid accumulation. And I'll either listen to a couple songs on the radio or time the clock and truly wait 5 minutes. And that usually helps prevent this from happening.
Does anybody at that point decide to do a direct exchange rather than risking slipping a second time? Dr. Devenye, you're nodding.
Yeah, I do routinely do direct PFO silicone exchange, if that's what I'm
It'll
doing.
solve the problem of slipping.
Yeah.
The other thing, Rick Kaiser taught me, you can do a little radial retinectomy in these cases, and it makes it kind of look like a Dick Green histopathology slide, which just kind of, in those horizontal pieces of the retina, it'll sit down quite nicely.
I think, Sunir mentioned the part, really the key is to give it some time if you're under air. Just let it dry out, leave the PFO up towards the edge, and just be patient and let it dry. It will.
Fair enough. Okay, next, we have a 51-year-old patient who is phakic, has a PVD and a superior retinal detachment from 10 to 2 o'clock with a single tear at 12:30. I performed the pneumatic retinopexy, and 15 days later, the patient has a recurrent retinal detachment with a break at 5 o'clock. In Canada, would we do another pneumatic retinopexy here? Would we put in more gas, cryo the break, and make them stand on their head?
I'm not big on pneumatics personally, but it's possible that we certainly could. And if it works, great. Otherwise, I would do a phaco-vitrectomy if it didn't work.
Ehab, I'm going to say one hint is the answer is not a suprachoroidal anything. So
Well,
how would you manage this?
I'll go for a phaco-vitrectomy also.
Phaco-vit.
Yeah.
Would anyone now say, boy, I failed the pneumatic, I'm going to do a buckle vit, or just a buckle? Andrew?
Yeah, I would definitely do a buccal vitrectomy. I probably would not do a phaco unless I couldn't see well enough.
Dante, you're nodding?
Yeah, I'd probably do the same. I mean, these cases, the more times you operate, the worse the outcome. If you can fix a detachment with one procedure, that's the best way to go. So since we failed already once, it's an inferior tears, I'm going to hedge my bet. This is a phakic patient as well, so they're going to probably need the lens out.
Dean Elliott taught me his rule, which is if you do a second retinal, at the end of the second retinal detachment repair, there better be a buckle on the eye. Doesn't mean it has to work, but you better have tried both. Okay, here's a 51, so we did that. A 73-year-old with macular hole and cataract. They had a PVD. This is the hole, so we're going to probably do surgery, but how are you going to think about the lens? We just heard from Jenny about combined phaco-vit. We know to the right of the panel, that's what they're going to do. How about for the Americans with a limited repertoire in the OR? How are you going to proceed? Dante?
Usually I would just do the macular hole surgery first and then do a secondary. I mean, there are some cases where the patients really want to do it, and because of referral patterns in the United States, I'll have the cataract surgeon come in and do it at the same time, but it's just for referral issues. I do think the outcome probably going to get a better IOL calculation if you did it secondarily, but maybe not.
Does anybody do the cataract surgery prior to vitrectomy?
I always try to advocate for that. Sometimes the cataract surgeons want to do that, sometimes they don't, but I usually go with that
I
approach.
tend not to like that.
Fair enough. So, Sunir, despite being at Wills, you're doing this case with one of your fellows and she happens to violate the lens with the vitrectomy handpiece, takes a little bite out of the posterior capsule and maybe a little bit of lens material. You jump in the seat, you remove the ILM, and you finish the case. How do you manage the lens? Does it have to go now?
So I've done this both ways, and whatever way I chose, I always wish I did the other one. So, sometimes if you take a small little bite out of the lens, you put in a little bit of triamcinolone to modulate some of the inflammation. That'll work okay, but then you're going to have to find a cataract surgeon who's going to want to operate on that eye for you, and that becomes the issue. And so a lot of times I will end up then just doing a lensectomy and leaving sufficient capsular support for either for an in-the-bag lens or probably a sulcus lens later. And that seems to work pretty well. It just requires a lot of explanation to everybody afterwards.
Andrew, similar?
Yeah, I would definitely take the lens and finish the rest of the procedure as I would have done previously.
Yeah.
One of the things is always these patients will have to preoperative biometry. Like once it's scheduled for vitrectomy, you always have a biometric. It could happen.
Only if you can fix it, which I can't, so not necessary. So speaking of lenses, we have a 67-year-old. Now this person had a phaco IOL in 1997, and now they have inferior subluxation of the lens, secondary to a nasal haptic, which has broken, and you can't see it. This is the temporal haptic. Dante, what are you going to do about this?
Well, you gave us a date, so it's probably an all PMMA lens, a hard lens, not a foldable lens. It's broken, so the lens is going to have to come out of the eye, and then a secondary lens placed. And there's a whole bunch of ways you can do that. I tend to be, maybe it's because of my age or whatever, I tend to be an anterior chamber lens person. I think that these things, you're going to have to take this thing out of the eye. It's going to have to be a relatively big wound anyhow. Anterior chamber IOLs do very well in most patients. I think most of the endothelial cell loss is not from the ACIOL versus a PCIOL, but how rough you are with the surgery and putting the lens in and taking this lens out. So
That's fair. Now, most lenses in 97 were not PMMA, so how did you know that was the trick?
what were they made out of then?
Made of other materials, acrylic and silicone?
Oh, no, I thought that's what they were.
That was the trick. So I didn't know that at the time. I didn't know it was PMMA. So I went in, I was planning on doing an IOL exchange. And so I made my 2.8 millimeter clear corneal incision to go ahead and cut and remove the lens. And when I went to cut it, it was a PMMA lens and my scissors almost broke. What am I supposed to do now, Dr. Devenier? How do I have the big corneal, I have a corneal incision, I have a big lens that's not going to fit. How do you manage that?
So I'm not sure I heard the question correctly. One of the haptics was broken, and
Yeah,
where was
you can't
it?
rescue this lens.
But where is the other haptic, in the vitreous?
Yeah.
Because if it wasn't in the vitreous, I would just have sent this to my anterior segment colleagues. But if the lens, if there was a piece of haptic in the vitreous that needed to be removed, then yeah, I would retrieve it first with a vitrectomy, and then I don't think you have a choice but to make a big incision and to take the lens.
So would you extend the clear corneal incision and make it 6 millimeters, or would you close that and make a scleral tunneled incision?
No, I would just extend.
You
I would
have?
extend it.
Well, you could do both. Even if you extend the corneal incision, just putting a suture that you can remove the second post-operative day, you don't concern about the astigmatism. I mean, getting the job done the first time is very important than thinking about one diopter astigmatism that you can correct.
Right, for sure. So you decided, okay, I'm going to take it out. Now you have this 6 millimeter clear corneal incision. Andrew, would you then place a ACIOL?
So I'm definitely a fan of ACIOLs. I believe in Demetrius Vavas's approach. He gave a great talk at the Duke course this year on the value of ACIOLs. And they work great, predictable. They don't fall to the back of the eye. So that would be my approach.
So that's what I should have done, but I'm stubborn. So I decided I was going to continue with my Yamane procedure, and I took the first lens out, put in my second lens, externalized the first haptic, thermally deformed it, and things were going swimmingly. And then when I started to work on the second haptic, I pulled the first haptic into the eye again. Mm-hmm. So now I have a thermally deformed tip on my haptic, and I'm kind of stuck and pretty much ready to commit suicide for not putting in an ACIOL. So how am I going to get out of this situation? Sunir, what can I do now with this?
Put in an ACIOL.
So just take it out and give up?
That's, at some point during the surgery when things if you start to lose your cool and it's just going bad, you know, just go to what's going to help you get the surgery done, get the patient rehabilitated, and get you out of there.
And that's what I did. I said enough's enough. But one tip is if you are doing these Yamane procedures and the bulb is created, you know, you can't put it back through the needle because it's too big now, but you can use the vitreous cutter to just snip off and excise the tip of it. So we had a bunch of other cases, but we are out of time. Thank you for allowing us all to participate. Great panel. Thank you, guys.
Short change.